physiologist, basic physiologist. I work in the cardiovascular system and GI tract. And I can see that you guys have a problem. And we have to start from the basic. You know, I'm from Central Lancashire, and I teach pharmacy students and basic science students, and sometimes we only spend 1 hour, probably 2 hours, just teaching fluid exchange. You need more than that, the basic. If you have the real basic, you understand the exchanges and glycocalyx and so on. It seems like the glycocalyx is taking up all the fluid. One of you said you give the patient 2 liters and he disappears, just like that. But if you can teach the student the histology, the physiology, the basic, and so on, that's first part. The second part, which I've noticed, you guys are the physician, and some of you prescribe one thing, the next one prescribe another, the other one prescribe another. And we never thought of some of these things are dangerous. Somebody had it on the board. A drug is a good drug in a therapeutic dose, but when you use it higher, you kill the, you had it, you kill the patient. And again, somebody ask a question about albumin. Is this albumin is sucking up some of the ions or whatever it is, and so on. So it's a big problem here. And you the guys will have to come and write something very simple for the students to learn. Once they understand the basic, I'm sure they will follow the rest. I don't know if I'm talking nonsense.
I would like to say something to that. I like your enthusiasm, and I think it's important to do a lot of research in physiology. But from the clinical point of view, the state of physiology does not link to the clinician, to the state the clinician is in. I'm going to make this clear. Now, the NICE guidelines have put this together in a way. They say, please assess hypovolemia. And how do you assess hypovolemia? Are there indications of mottled skin, dried skin? I mean, these are all, or blood pressure. You put together a clinical picture. What you are trying to say is that we have physiological evidence. Now, we would love that. Yes. I've been. No. No. And this is, I want to make this quite clear. I've been traumatized by basic science for the last couple of years because this was used. This was used to condone colloid therapy. People waving the flag of Starling, not having understood it properly and everything. Basic science is never a reason for clinical practice.
But that's a background you need to understand. If you understand physiology, it helps you in diagnosis, it helps you treatment as well.
Right. I think we need a lot more understanding on the physiological level, and there are many avenues that have to be followed here and that lead forward. But in the end, the proof of the pudding is the clinical trial.
So, I think I both have something to say about that. So I think the challenge those of us who try and work from the basic science would have with the clinical trials is the enthusiasts for colloids said that they thought they made sense in a situation where the glycocalyx was likely to be intact and the patient had a true volume deficit. So that would have seemed to be a logical extension of what we knew from the basic science. The trials were done in patients who were critically ill, who were pre-resuscitated, who had a high probable total body salt and water, who had pre-existing high hydrostatic pressure, and probably had no glycocalyx. Working from basic science, you would say, do not do that trial, because working even from Starling's original model, or the modified version, it's the wrong thing to do. But those were the trials that were done, who've then been translated into saying, we now know what would happen if you did the right trial, which was in the situation where you think you've got those other preconditions. So we've condemned the colloids, having not determined whether they do or don't work in an environment where basic science would say they might. It's a long statement.
That's something what is really missing as well. I didn't see it only to the mortality rate in some of these different things. I didn't see that really. But that's something you guys have to consider. I would have loved to see how many people died from different things.
I think it's very important what you said, certainly. And I'm absolutely also with Christiane that outcome-based evidence is very important. But I think what we missed, especially in the colloid and fluid and crystalloid discussion during the last years, and which we should bring back to the discussion is the fact that if we cannot cover a certain clinical situation with the available outcome-based evidence, then this is a decision whether we have to extrapolate the available evidence to the clinical situation or whether we have to think physiologically. And I'm convinced in the context of fluid and volume handling in 2014, we should base our strategies on physiology and pathophysiology and reevaluate these strategies by the available outcome-based evidence, because if we do it in a different way, we accept therapeutical freestyle in 98% of all our patients because we say there is no evidence, we can do what we want. And so I think this is the combination we need currently, because if you are evaluating 2 antibiotics, it's quite simple. You take the one antibiotics and the other and compare between 2 different patient groups. This cannot be done in a supportive measure like fluid and volume handling. And so I think physiology is very important to cover all the other patients where there is no available outcome-based evidence. This has been forgotten.
So just before you manage to ask your question, just a brief thing on the lymphatic side. Relatively recently, there's the animal kind of models that I showed at the beginning of my talk and so on. The zebrafish is now much more accessible than it was, I don't know, 10 years ago, say. And you can therefore you can have in your field of view when you're imaging, you can have blood vessels and lymphatic vessels and so on, and do multi-scale. So you can do the EM, you can do the light microscopy, you can do X-rays, and all of these other techniques is now sort of possible from a basic science point of view. You can now do those experiments which weren't really feasible before. I just thought I'd add that in.
I was just going to add my 5 pennyworth to the comments that have been made. And that is concerning the role of basic science in medicine. I somewhat reluctantly qualified in medicine, did my clinical training, because by that stage I decided I wanted to be a physiologist. And the thing that I learned by doing clinical medicine was how much physiology was there, which I didn't understand. I found that greatly challenging. And I think the dangers when basic science is used in medicine is people accept it as a truth. Most practicing physiologists see it as see conclusions as a working hypothesis, or at least a principle that can be revised. And I think that's a rather difficult thing to pass on to clinicians. I remember I was always immensely critical as a clinical student, but I remember one night being on call and going to casualty and knowing that there was an unconscious patient there, and suddenly realizing how useful these acronyms were. You know, it was damp ivy or something, drugs, acute infection, etc., metabolic, pressure, etc. We went through, but it was a great sort of guide. You need those sorts of things to make quick decisions in medicine. But when you're actually thinking about what you're doing, you've got to go back to the science. And you've got to actually look at the science as something which can be revised, that something isn't absolute. I don't believe in absolute truths, except in mathematics.
Thank you, Charles. I actually do want to go from clinical observations to basic science, so perhaps this is a good thing to do. And this addresses an issue that I think has not been touched on by anyone here at all. 2 decades ago, I made some observations in conjunction with some surgeons in Munich, where we observed that focal ischemia, as in ligation of one femoral artery during repair, produced a systemic response, so a bilateral response. Followed this up many years later with a young PhD student of mine who was looking at preeclampsia. And this is the issue. Nobody has talked about the effect of post-capillary margination, because in the preeclamptics, and this is really what I was looking at, I think they weren't preeclamptic surgical patients in Munich, but in the preeclamptics,
there were massive changes indicating inflammatory response. And they related beautifully in mathematical, graphical terms to the upregulation of adhesion molecules. Now, post-capillary margination is going to influence the pressures you're getting at the microvascular interface. It's going to alter the way in which fluids are going to move across the microvascular interface. It's going to alter the balance of fluid within the patient. I think this is so terribly important. So why isn't this being addressed by everyone? You should be standing on the rooftop shouting, upregulation of adhesion molecules is important, because I think it actually is. Thank you.
I'm so excited by that comment, because the whole reason for getting physiologists and clinicians into a room today is to hear just that sort of thing. Inspirational. I hadn't thought of that. That's going in my next review article. Of course, once the white cells marginate, they are going to change things like capillary pressure, like shear force, traffic jams. Brilliant. And this is why clinicians have got to stay closer to physiologists, and we have to keep having these dialogues. Thank you. Yeah.
Just a quick comment. Why, I'm being naive here, why is the teaching of medicine still relying on textbooks? Why is it still relying on textbooks? Because nobody in science degrees relies on textbooks.
A standard, I guess. Most of the teaching is done by clinicians in the clinical circumstances, but they are running on stuff they learned when they were students. Yeah.
So is there no updates or revision of syllabus, or how often does it happen?
I don't think so. It doesn't. Sorry, there's a question there.
A lot of the more science part of the medical courses is done in the preclinical section right at the beginning, and that is done in a combination of different ways. It's not just textbooks, but a lecture is got with pictures from textbooks. It's the way it's not physical textbook. They have little booklets they can carry around and cheat from. That's really what they use.
I think they tend to dump last year's knowledge to be able to get this year's knowledge in. Yeah.
I've got a more generic question, and Monty referred to it very briefly. Is it time to retire the concept of p-value? Should we stop using it in medicine?
0.05, possibly.
We're slightly unusual as clinical trialists to have the obsession about 0.05. Statisticians would have a different view. They would take a view and say any p-value has merit to determine the probability that was a finding by chance, and then you reverse engineer that back to the question you asked, the robustness, the likely biases, the power of the study. So the fact that a 0.09 means nothing, but a 0.049 means it's a certainty is a complete nonsense. So.
Would you like to You're the expert.
Well, yes, I would comment on that. If you look at most science, it is not reproducible. There is now a journal that is studying irreproducibility, and they find it all the time. I mean, the best example was a lovely one called the Lady Macbeth syndrome, where they showed that exposing subjects to a nasty story compared with a nice story made them choose more cleaning products. And it sounded wonderful. What a story. My hands have been dirtied by this nasty story, and therefore I need to cleanse myself. Complete garbage. And it was only got there because it was a small study which just by chance came up with a nice low p-value. That's the problem. Bernoulli's theorem still exists and works. In other words, small studies, small samples are very likely to be wrong. unrepresentative of the whole population. So really, I think that if we're going to set any standard at all for a p-value, it should be a lot lower than 0.05. Certainly for clinical purposes, certainly if it makes a difference to cost or outcome. Yes.
Could I say something to that? I'm not an epidemiologist, but I've been working with epidemiologists now for many years. This is a convention. You need some kind of a cutoff, and it's got good reasons for it. And of course, as you said, you will not kind of argue along the threshold now 0.049 or 0.051. There's not so much a big difference behind it. But I want to make it quite clear we have very good rules for clinical trials. And these are the important rules. And when these are followed, then you do get reproducible results. When you look at the Starch trials, they got amazingly reproducible results, although they were done with, which I showed you, with different starch solutions and in more risk or less risk patients. And now we have another set of very well-performed studies using hemodynamic measuring, monitoring performed by, this is a process trial done by Derek Angus, or the ARISE trial with a similar, these groups worked together and devised similar protocols, but they finished at different times. The US American has finished, the New Zealand Australian one has just finished, and the UK trial is ongoing and will finish soon. And already the first two are very reproducible, showing that clinicians, when clinicians perform fluid therapy for community-acquired sepsis, sepsis presenting in the emergency department, the outcome is similar than if a protocol is used or if an algorithm using hemodynamic measures is used. So these are reproducible trials because they were done according to very high quality standards of clinical trials. And I think this is something we need to acknowledge and to follow. And I would like to see more of evidence which is generated by these trials in textbooks.
Absolutely. But we should not forget that it's not only reliability, it's also the validity. Sorry, it's very late in the evening now. This is the problem. I think what also statisticians confirm on is that the higher your reproducibility is, the more difficulties you have to be close with clinical practice. This is also with early inclusion of patients in trials or some things like that. I think we should always keep that in mind. So being close with reality, being close with daily life, being close with those patients you are treating every day means to being more far away from reproducibility. That's a problem. It's a methodological problem.
Thank you. I was really thrilled to see that there's a great fluid therapy research lab next door called the King's Arms, where they serve plenty of starches. But as I approach retirement here, one of the things that I reflect on is a sense of shame, and I'm part of the shame that physics since 1896, 118 years ago, has moved on enormously. We're putting rocket ships on moons, and we're still sitting here debating a colloid crystalloid thing that went. And I would suggest that we are all consumed by colloid therapy. And as Charles mentioned to me when we were having a discussion once, there are lots of other interesting chemicals around that might have something to do with the glycocalyx, might have something to do with our balance. A rosamucoid, I think, was one you reminded me of. There are lots of other things that we could be concentrating on if we stop focusing at least exclusively on colloids and colloid osmotic pressure. We may be able to take our research in far more fruitful directions. 120 years has been enough.
But this is a very small group. I think the vast majority of people don't care.
Yeah.
So that's worth reflecting on, I think, yeah. And it's probably because it doesn't matter. That's why we're still debating it.
Yeah, just to sort of complete the story about the harmful effects, especially on the kidney that I was interested in, about saline and colloids. Is there either one or probably two fairly convincing pathogenetic mechanisms for their harmful effects, or is that not really quite clear? Because it would sort of help to convince everybody, I think.
The chloride, the mechanisms are fairly well described as what may or may not be causing it. Other people comment on the colloid, but my difficulty interpreting the colloid research is when you use other equally oncotic molecules, the suggestion of what might be the pathogenesis behind the injury is less clear, and toxicology in animals is not a clear nephrotoxic effect, because that was all done with all the molecules prior to approval. That's the one thing they do, is very, very high dose tox studies. So it's difficult to understand why everything that's had an approval process had massive overdose tox studies, and nephrotoxicity would have been a showstopper.
The mechanism of colloid nephrotoxicity is not completely worked out, but an important part is these osmotic nephrosis lesions. They probably occur because starches are taken up by the cells and then draw water, and the cells bloat, become big, and obstruct the tubules. And this does not need to be bad because you have many cells, but it's a problem of numbers. If it affects many cells, and if the kidney is also a little damaged and has no reserves, then this is a big problem. The French discuss, around Frédéric Schottgen, they discuss hyperoncotic solutions and hyperviscous urine. I'm not sure about this. This may also play a role.
It's not clear.
It's not completely clear, but
you think it would be bound or clear.
Years ago, that the hyper-osmotic problem was overall colloids causing renal damage. Hyperviscosity syndrome
So-
like osmotic diuretic, isn't it?
So yes, you get the similar lesions by mannitol, you get them by immune globulins, from immune globulins. But the problem with colloids is it's just so, you give so much and you give it for such a long time, comparatively to just an injection of like immune globulins. So that's the problem. And the kidney always stores several-fold amounts of colloids compared to other organs. All the studies also in humans, post-mortem, show that the kidney takes up to 10-fold the amount of the colloid that's being deposited.
Sorry, I know very little about these colloids, except as this meeting was coming up, when I happened to see a paper, the title of a paper on the effects of the starch colloid that's used. It was a paper in which the components of the colloid had been examined for their molecular weight, and the experiments had been carried out on cultured renal tubular cells, and it showed that the damage to the cells occurred independently of the size of the molecule. It did a dose response curve on the effects of these different molecules. It was a fairly thorough study. Now, I'm being rather ancient, I'm afraid I don't remember the name of the author of the journal, but I could find them out for you. Neuhaus.
It's not oncotically controlled.
Yes, it's not oncotic.
There was another question somebody wanted to ask.
Just to bring it back to sort of clinical, if I may, I'm anaesthetic trainee, intensive care trainee. I think just highlighting with the junior doctor's point of view, you mentioned that we're a very small audience and people are interested in fluid, but actually I think the junior doctors really don't care. And I think that might be perhaps controversial for some, but because it's not highlighted, and I know there's some work up in Edinburgh and Lothian to highlight that as an interesting point, The IR1 forms may have a sort of a relevance with that, but really I think it has to trickle down from the senior medical people on the wards that it's important. You know, you see the hyponatremia, the hypovolemia, or the hypervolemia when they come to ITU. But actually, when they're treated on the wards as a medical student, it was the textbook that the lecturer had written, which we were told to read. And that was where we learned about something about the glycocalyx, but that was in year 1 and 2. And by year 4, really, I just needed to pass an exam. And it wasn't brought back to the relevance of the glycocalyx. It wasn't brought back to the relevance of the renal tubule. And it was only when you start doing anesthetics and then there's another exam which talks about physiology, you think, oh, maybe it's relevant. And I just wonder how perhaps, although we've published the guidance, how actually we might bring that back to the person who's prescribing. And I know we talked about IR1 forms, so I don't know whether the panel had any thoughts about how the junior doctor might be encouraged to be interested.
Does it, and it's the clinical director, if you like, who's responsible. I had great fun this week writing to all the clinical directors in Lothian and telling them that I knew that their junior doctors were doing it wrong because we'd done an audit. And our audit was completely balanced by the data of the pharmacy on the fluids they sent to the wards, which were again in the ratio of 2.4 of saline to 1 of dextrose, which is exactly the wrong way around. And I told the clinical directors that we knew what was going on because we were following the pharmacy. And therefore, we knew who was going to make a change and who wasn't. In other words, you can actually follow that quite easily. You don't have to spend ages trotting around making lots of audit forms, filling out audit forms to the ward. The pharmacy will tell you immediately who's doing it right. And it's quite a good weapon to have.
And I hope you'll see quite a change in the next 2 or 3 years, because the nice requirement is that you have these leads, these endeavours, and it is getting traction in very many places of a similar style to that was described by our chair. And that the next thing that happens after that, in say 3 to 5 years' time, is that people will begin to fail their quality inspections. So chief executives will be nervous and anxious about the fact that they're not complying with nice guidance, etc., etc. It's not going to happen overnight, but I think you'll start to see some traction.
Chemistry. They can spit you out anonymized data often very easily. And it's very interesting. Fife, a little kingdom just north of Lothian, has been doing this a little longer than we have. They've looked at their clinical chemistry results and they've found no increased instance of hyponatremia in the post-operative, well, in general patients, including post-operative patients, and they've introduced 0.18% sodium chloride, 4% glucose, which is, if you like, artificial urine, perfect for maintenance. And that's what NICE would suggest as one of the potential solutions.
If I might offer a little thought on chloride again. When I arrived as a consultant in Southampton and found that chloride was not offered by the laboratory, they just would not measure it. And I spent a year or two being as firm and as incisive I could, demanding that I get chlorides. And eventually chlorides were made available to the general intensive care unit, but no one else. And Monty, I understand that is still the case in Southampton. Chlorides are still not available to doctors outside of the intensive care unit. So that's something that's got to change, isn't it? We've got to get chlorides available throughout all the hospitals. It's going to cost a lot of money. Now, that's the other interesting thing. Last week, I know you don't like anecdotes, but the consultant in the theatre next to me came running round, said, I'm on my 3rd litre of Hartmann's for this laparoscopic operation, and the chloride's now up to 118. Shall I give more Hartmann's? I said, no, stop giving Hartmann's, just turn it off, do another blood in an hour and come back. She did that, the chloride had gone down. You presume that Hartmann's does not cause hypochloremia and that sodium chloride does. But one of the wonderful things is that human beings, especially after they've had an operation and under an enormous vasopressin dose, are quite capable of desalinating a litre of normal saline and becoming hyponatremic. You can become hyponatremic very easily on normal saline. Its volume, I don't agree with you. You've been pressing a lot about sodium is bad, we mustn't give people sodium. I completely disagree with that. It's water that makes edema, not sodium. And I think that we're over beating. We're suddenly now beating on chloride, where it's taken us. It's been hard to get anyone to measure it. Now all of a sudden it's demonic. I mean, and another anecdote. In my neurosurgical intensive care unit, I can't tell you the amount of chloride they're pouring in, and no one's going into renal failure, and no one's complaining of abdominal pain. And what the other things chloride does? Yeah, well, and someone will say, "Oh well, they're not the same as intensive care patients." Yes, they are.
Okay, I'll have to draw this to a close. We've now reached the witching hour of 5 o'clock, and I'd like to hand over to Mike Grocott to present the prizes.
So it falls to me to make some closing remarks, and I'm slightly embarrassed that I wasn't here at the beginning of the meeting, and regretful because it sounds like you had some fantastic presentations. I think it's a cause for celebration. So I've loved the heat and light generated by our panel. I think it's some really interesting discussions. I think it's a cause for celebration that the Physiological Society and the Association of Anaesthetists of Great Britain and Ireland have come together to look at this problem across the spectrum. And I think you've heard some fantastic talks from real experts, from the basic scientists right through to clinical science and clinical trialists, from those beautiful photomicrographs up through clinical trials with hundreds and thousands of patients and an epidemiological data with hundreds of thousands of patients. I suspect at the end of it all, you're still left somewhat uncertain. And I'm going to borrow a quote from Monty from a few years back. I do hope that you're confused at a slightly higher level. I hope some people go away with ideas for new experiments which might resolve this uncertainty, but I hope everybody goes away with a resolve to speak to your clinical colleagues, and particularly your junior clinical colleagues, and educate them about the basics. So forget the crystalloid-colloid debate, but thinking about fluids as drugs and who you're giving them to and why you're giving them, and the basic sort of principles that were laid out in the NICE guidelines, which whilst they can appear facile, it's very clear that lots of people out there do not appreciate them. So it is incumbent on us to share those principles.